Welcome back to the deep dive. Today, our mission is really specific. We're getting into the neurology of the spinal cord, but we're tackling it from a hands-on manual therapist's viewpoint.
Yeah, absolutely.
We're trying to skip the really dry textbook stuff and jump straight to the anatomical links that actually, change how you approach things clinically. And we'll build up to this pretty amazing finding in the upper neck that connects muscle tension right into the central nervous system.
That's so important. Because when you, the listener, put your hands on someone's back or neck, you're working within this incredibly integrated system.
Right.
We really need to move past seeing the spine as just like bones and muscles stacked up.
Yeah.
It's the main protective housing for the CNS.
Okay.
And to treat things well, especially the persistent stuff like, say, cervicogenic headaches, you've got to understand the layers, the pathways, and how tension on maybe just one tiny muscle can send forces through the whole neural setup.
Okay, let's start with that basic architecture then. We know the spinal cord is inside the vertebral canal, but where does the actual nerve tissue begin and end?
Right. So the spinal cord itself, it kicks off right from the foramen magnum, that big opening at the base of the skull.
Okay.
And it runs down inside the spine until it tapers off into a cone shape that's the caudus medullaris. This usually happens around the L1 or L2 vertebral level in adults.
And it's interesting that the cord stops growing much earlier than the skeleton, right? Like around age 4?
Exactly. The bones keep going, but the cord itself stops lengthening.
Which explains why we have that structure below L2, the cauda equina. Looks like a horse's tail.
It's all those nerve roots peeling off the end of the cord and traveling down to exit at their specific lower levels, like the sacral and coccygeal segments.
So it's like a bundle of wires extending beyond the main cable.
You got it. And the whole thing isn't just floating there. It's anchored down at the bottom to the coccyx by the filum terminale,
Oh, okay.
which is basically just a thin strand of the innermost protective layer, the pia mater, keeps it stable.
And the cord isn't uniform in width either, is it? There are those enlargements.
Right. Two noticeable bulges. The cervical enlargement up top that's got extra processing power for the shoulders and arms.
Makes sense.
And then lower down, the lumbosacral enlargement for the pelvis and legs. They're visibly wider because, well, they need more neurons to handle all the complex movements and sensations of the limbs.
Okay, architecture down. Now, protection of the meninges. We often use the mnemonic DAP, dura, arachnoid, pia. For us as manual therapists, which of these is most mechanically significant? Is it that tough outer layer?
It's absolutely the dura mater, the tough mother. Well, the pia mater is delicate, supervascular, and basically glued to the cord surface. The dura is this thick, dense, fibrous connective tissue. And mechanically, the reason it's so key is its continuity. Think about this. The wrapping around every single peripheral nerve.
The epineurium.
Exactly, the epineurium. It's directly continuous with the spinal dura mater.
Whoa, hang on. So if I'm doing, say, a nerve glide technique on the sciatic nerve way down in the leg,
Yep.
I'm actually putting some degree of mechanical tension on the dural sheath all the way back up near the spinal cord.
That is the absolutely critical connection to grasp. It's not separate sleeves. It's one continuous mechanical system.
Wow. Okay.
And thinking about those layers again, just outside the dura, you have the epidural space. That's where you find fat and blood vessels.
Right, where epidural injections go.
And then deep to the dura, tucked underneath, is the arachnoid mater. It's much more delicate, kind of web-like.
And the space under that one, the subarachnoid space, that's where the cerebrospinal fluid, the CSF, hangs out?
That's the spot. CSF circulates there, cushioning the cord, providing nutrients. And clinically, that's where a lumbar puncture or spinal tap is done, usually below L2, safely away from the end of the actual cord tissue.
Got it. A built-in safety zone based on that anatomy we just talked about.
Precisely. So that protective structure brings us right inside the cord itself, to where the actual processing happens and where all the information highways are.
Right, the cross-section. You see that classic H shape or butterfly shape of the gray matter. That's the unmyelinated stuff, right? Cell bodies, glial cells.
Yeah, the processing centers. And the wings or horns of that H shape are functionally divided. Very neat division, actually.
Okay. How so?
Well, the posterior horns, the ones towards the back, they're purely sensory. All the information coming in from the body, touch, pain, temperature, info from your organs, it all arrives there first.
Incoming data.
Incoming data. Then the anterior horns towards the front, they're strictly motor. They house the cell bodies of the somatic motor neurons, your lower motor neurons, sending commands out to your skeletal muscles.
Sensory in the back, motor in the front. Got it. And what about those lateral horns? You only see them in certain sections.
That's right. primarily in the thoracic and upper lumbar segments. These lateral horns are command centers for the autonomic nervous system.
Ah, the involuntary stuff.
Exactly. Specifically, the origins of the sympathetic nerves, fight or flight responses, regulating organs, that sort of thing.
And the bit connecting the two sides of the H.
That's the gray commissure. It's full of interneurons, basically connector neurons, allowing the right and left sides of the cord to communicate. And right in the middle of that is the tiny central canal, which also contains CSF.
Okay, so gray matter is for processing. Surrounding it is the white matter. This is the myelinated axons, the fast pathways.
Yep, the communication superhighways, bundled together into columns anterior, posterior, and lateral columns. And within these columns run the specific tracks.
And the naming convention here is really helpful, isn't it? Tells you the direction and function.
It's perfect. If you know the name, you know what it does. We group them into ascending tracks, sensory info going up to the brain, and descending tracks, motor commands coming down from the brain.
And this is where knowing the neuroanatomy helps you predict or understand symptoms directly. If a track name starts with spino,
It's sensory, heading up towards the brain, like the spinothalamic tracks.
right, like lateral spinothalamic for pain and temperature.
Exactly, and anterior spinothalamic for crude touch and pressure. There are others, of course, like the words for fine touch and proprioception in the posterior columns, fasciculus cuneatus for the upper body.
Okay, and then the descending ones, they end in spinal.
Correct. Motor commands coming down. The big one everyone knows is the corticospinal tract, coming from the cortex down the spine.
And even that splits, right?
It does. The lateral corticospinal tract is huge, controls voluntary, skilled movements, especially of our limbs, crosses over high up.
So damage there causes problems on the opposite side of the body.
Usually, yes. That's your classic upper motor neuron lesion pattern. If the damage is high up, think spasticity, hyperreflexia. Then there's the anterior corticospinal tract, which stays more central and controls the trunk muscles, more postural control.
So understanding these tracks means if someone presents with specific sensory loss or a particular type of motor weakness, you can start to pinpoint where the neurological issue might be along these pathways?
Precisely. You're not just guessing. You're correlating the functional deficit with the known anatomical pathway. It makes assessment much more targeted.
Okay, that internal wiring makes sense. Now, moving back outwards, these signals have to get out to the body. That's the job of the spinal nerves. 31 pairs.
31 pairs, yeah.
Yeah.
Named for the vertebral level they exit from, mostly. C1 to C8. Remember, there are 8 cervical nerves, even though there are only 7 cervical vertebrae.
Right, C1 exits above the C1 vertebra, C8 below C7.
Then T1 to T12, L1 to L5, S1 to S5, and one tiny coccygeal nerve, C1.
And each spinal nerve starts as 2 roots coming off the cord.
2 distinct roots. The posterior root, or dorsal root, is purely sensory fibers heading into the posterior horn. It has that swelling on it.
The dorsal root ganglion, DRG.
That's where the cell bodies of those sensory neurons live. Then the anterior root, or ventral root, carries only motor fibers out from the anterior horn.
Sensory in the back, motor in the front again, same pattern.
Consistent design. These 2 roots then merge together just outside the spinal column.
To form the actual mixed spinal nerve. Mixed meaning it has both sensory and motor fibers now.
Correct. But it's only mixed for a very short distance. Almost immediately after forming, the spinal nerve splits again into branches called rami.
Okay, rami. What do they do?
The smaller posterior ramus curves around to the back. It supplies the deep intrinsic muscles of the spine, like the erector spinae, and the skin directly over them.
So innervation for the back itself.
Pretty much. But the much larger branch is the anterior ramus, or ventral ramus. This one sweeps forward and laterally.
And this supplies basically everything else.
Almost. It supplies the muscles and skin of the front sides of the trunk, and crucially, all the muscles and skin of the limbs, arms, and legs.
Ah, so the anterior rami are the ones that are going to form those complex networks for the limbs?
Exactly. They're the source material for the plexuses.
Before we get to plexuses, though, let's talk about mapping this out clinically. Dermatomes and myotomes.
Absolutely fundamental for assessment. A dermatome is like a specific territory of skin that gets its sensory innervation from a single pair of spinal nerves.
So like bands running across the torso or down the limbs?
Yeah, there are standard dermatome maps. They're incredibly useful because if a patient comes in with numbness, tingling, pain, or even a rash mook, thinks of shingles.
Which follows a dermatome perfectly.
Exactly. If the symptoms follow that specific dermatomal pattern, it strongly suggests the problem isn't just a local issue in the skin or muscle, but rather an issue affecting that specific spinal nerve root, maybe from a disc herniation or stenosis.
Pinpoints the level of the lesion, and the motor equivalent is the myotome.
Right. A myotone is the group of muscles primarily innervated by the motor fibers from a single spinal nerve root.
And we test these with resisted muscle actions.
Correct. For example, resisting shoulder abduction tests the C5 myotome. Resisting elbow extension tests C7. If you find specific weakness in a myotomal pattern, especially without obvious muscle wasting yet, it again points towards that nerve root level as the source of the problem.
Okay, so dermatomes for sensory mapping, myotomes for motor mapping, both helping localize issues to a spinal segment.
You got it. Invaluable assessment tools.
Now, back to those large anterior rami that supply the limbs and trunk wall. You said they form networks? The nerve plexuses.
Yes. Instead of just running straight out, the anterior rami from adjacent spinal levels braid together, interweaving in these complex networks called plexuses.
Why do that? Why not just have one nerve go to one muscle?
It's like a safety feature, redundancy. By blending fibers from multiple spinal levels, say C5, C6, C7, a single peripheral nerve emerging from the plexus might carry axons from all those roots.
So if you damage one single spinal root?
You might get weakness, but you likely won't get complete paralysis of a muscle or total numbness in an area, because it's probably receiving input from other roots via the plexus.
Smart design. And there are 4 major ones.
4 main ones we focus on. The cervical plexus up in the neck, roughly C1, C5. The brachial plexus for the arm, C5, T1. The lumbar plexus for the anterior thigh, L1, L4. And the sacral plexus for the posterior thigh and everything below the knee, L4, S4.
Okay, we won't dive deep into all the branches today. That's definitely another deep dive.
For sure. The brachial plexus alone is a lot.
But understanding that these plexuses arise from those anterior rami is key. Everything we've discussed, cord structure, roots, rami, it all feeds into these networks that run our limbs.
Exactly. That foundational anatomy is the source code for everything downstream.
Which brings us perfectly to the clinical application that ties so much of this together, especially for us working hands-on, the myodural bridge. This is relatively recent stuff, isn't it?
In the grand scheme of anatomy, yes. It's really gained attention over the last, say, 20, 30 years. And the findings are, frankly, pretty stunning.
Okay, what is it?
Researchers doing meticulous dissection studies, particularly in the upper cervical region, found this consistent, dense connective tissue connection. It literally forms a bridge.
A bridge between what and what?
Between some of the deep suboccipital muscles, specifically the rectus capitis posterior minor, or RCMI, and the actual dura mater, the tough outer layer protecting the spinal cord.
Wait, a direct physical connection from a tiny muscle at the base of the skull to the dura.
Unequivocally, found consistently in cadaver studies. The connective tissue fibers run from the muscle and insert right into the dorsal dura, mainly around the C0, C1, C1, C2 levels. Other muscles nearby, like rectus capitis posterior major and obliquus capitis inferior, also show connections. Maybe less defined, but still there.
Okay, my mind is slightly blown. Why would that connection exist? What's the theory?
The leading hypothesis is that it's protective. Think about head and neck extension. As you look up, the RCMI likely contracts slightly. And this gentle pull on the dura, via the myodural bridge, the MDB, might help prevent the dura from folding or buckling inwards. Dural infolding could potentially put pressure on the spinal cord in that very mobile area.
So it helps maintain dural tension and space for the cord during movement.
That seems to be the most plausible function. It maintains dural integrity.
Okay, but what happens when things go wrong? What if that RCMI muscle is chronically tight? Like someone with forward head posture or after whiplash.
Now you're hitting the clinical core. If that muscle is hypertonic, constantly tight, and maybe even spasming, that abnormal excessive tension is transmitted directly through the MDB to the cervical dura mater.
Pulling on the spinal cord's protective sheath.
Exactly. And this chronic mechanical pull is now strongly suspected to be a major contributing factor, maybe even a primary driver in conditions like cervicogenic headaches.
Headaches originating from the neck.
Yes, and possibly tension-type headaches, too. You're creating direct mechanical irritation on the dura, which is highly pain-sensitive, or you're potentially putting tension on nearby structures like the C1 or C2 nerve roots, which are known culprits in head pain referral.
And it seems there's more. Something about the nuchal ligament also connecting.
Yeah, more recent work shows the nuchal ligament, that big ligament down the back of the neck, is also continuous with the dura, blending in via another ligamentous structure. So it's not just the tiny muscles. The whole posterior fascial chain potentially influences dural tension.
This paints a picture of a very mechanically sensitive system up there.
Absolutely. And add this. Studies using dynamic imaging show that even passive neck movements, like rotating C1 on C2, actually cause the spinal cord itself to move within the canal.
The cord shifts?
Variably. And interestingly, rotation often causes visible tensioning of the spinal nerve root on the side opposite the rotation. The whole system moves and adapts dynamically.
So abnormal muscle tension isn't just restricting joint movement, it's directly impacting the mechanics and mobility of the neural structures themselves.
That's the profound implication for manual therapy. When you, as a therapist, are working on releasing those tight suboccipital muscles.
I'm not just trying to get more neck rotation.
You are, perhaps more importantly, directly reducing that abnormal mechanical strain on the dura mater via the myodural bridge. You're influencing dural mobility.
Which could explain why releasing those muscles often helps so much with certain types of headaches.
It's a very plausible mechanism. Now, we need to be careful with our language, right? We can confidently say we're reducing abnormal mechanical tension. Claims about improving CSF flow are much more speculative at this point.
Right. Stick to the known mechanics. Reduce the pull.
Reduce the abnormal pull on the dura. Support normal dural mobility. That's the evidence-based takeaway for practice.
So understanding this whole chain from the cord structure, the meninges, the roots, the rami, all the way to this tiny muscular connection to the dura, it completely reframes suboccipital work.
It really does. What might have seemed like just treating localized muscle tightness now has a direct, demonstrable link to the central nervous system's protective environment.
Okay, let's try to wrap this up. We've gone from the gross anatomy of the cord through the protective DAP layers into the gray matter processing hubs and white matter tracts, out through the spinal nerves and rami, touched on dermatomes, and landed on this critical myodural bridge.
Yeah, quite a journey through the structure and function.
So the final thought for our listeners to really mull over.
I think it's this. That direct anatomical link, the MDB, means that local muscle tension in the neck isn't just local. It has immediate mechanical consequences for the CNS coverings.
And combining that with the knowledge that upper cervical movement physically shifts the cord and tensions contralateral nerves.
Right. Consider how your precise therapeutic touch in that suboccipital triangle by normalizing muscle tone isn't just about freeing up movement. It's potentially easing direct mechanical stress on the dura and influencing the neural mobility of that entire critical region.
That level of anatomical integration really elevates what we do. It's not just rubbing muscles, it's interacting with the nervous system's mechanics.
Absolutely. Knowing this anatomy, you practice with a different level of awareness and intention, and that's the goal, isn't it?